Good afternoon, everyone. I'm Dr. Brijesh Dubey here, the session in charge for the fourth and final session here of ANZAWR. This session is sponsored by Baxter, and it is my absolute honor to introduce our chairpersons here, Dr. Sue May Ho. She's a general and laparoscopic surgeon with a special interest in colorectal surgery, working at Lyle McEwen Hospital, North Adelaide, and Dr. Vivek Bindal, who's a laparoscopic and robotic surgeon, head of the Department of Surgery at Max Super Speciality Hospital in North India. Thank you. Over to our chairman.
Thank you, Brijesh, for that introduction. Good afternoon or morning or evening, wherever you're joining us, whether it be New Zealand, India, or here in Australia, and of course to our panelists in North America. It is my absolute pleasure to introduce Todd Heniford, the man who does not need any introduction in the hernia circles. As a chief in the GI and minimally invasive surgery department in the Carolinas, he's trained the likes of Yuri Novitsky, Igor Belyansky, Michael Rosen, and Vedra Argenstein, and who better than him to talk to us today about how to become a better hernia surgeon. So over to you, Todd.
Let's see if I can share my screen here. It says I can't share while others are sharing. Yeah, thanks so much, and I really appreciate, Sue, that was a very kind introduction. Thank you very much. And it's interesting you'd asked me to give a talk on how to be a better hernia surgeon. Well, I have gone through this for the last 25 years, showing myself how I was a bad hernia surgeon, and then trying to improve. And I had the wonderful opportunity to be in India a couple of years ago, and thank you very much for that invitation. And I'll have a couple of analogies that I really like that I'll share with you again. But otherwise, some additional information, my thoughts about becoming a better surgeon. Importantly, here are my disclosures. And no one, and it's amazing you see this group and some just fantastic surgeons. I've seen, been to New Zealand, been to Australia, now been to India, and seen some amazing videos, amazing surgeons, seen some remarkable techniques in taking care of patients. But when I was a chief resident at the University of Louisville, I would have had a patient such as this one that came in on the left side after trauma. He's got a great looking skin graft. He's alive after a massive trauma. And I would have said, put some cocoa butter on that skin graft. There's really nothing I can do for you surgically. But now being able to take this person and make them look like they look on the right side here is what many of us do essentially every week in our offices in the hospitals. And it has really, really changed. And as a hernia surgeon early on, even now in America, there's been a push to change the America's Hernia Society to talk about core health. And why would you change it to core health? It's interesting with that consideration is because what one of the people said is because people looked at me when I told them I was a hernia surgeon, and they're like, well, you just fix hernias? Like that's not good enough. It reminds me of this card that was given to me as a friend gave to me for my birthday, and you can see the unicorn and this mule, and says, we unicorns need to stick together. And then of course the unicorn says, is that a plunger on your head? Because we as hernia surgeons have always been looked at like hernias are just not special. Well, I will tell you that they are. We are reconstructive abdominal wall surgeons. We impact the quality of life and function of patients every single day. You can take patients like this on the left and transform them to patients like this lady now on the right side and really impact people beautifully. Again, patients after multiple failed operations, and then convert them to these types of pictures. Patients like this, totally dysfunctional, societally unacceptable, and you can create her, move her to someone that is certainly physically acceptable and treat her both physically but also psychologically amazingly. When I was asked to do this, and the consideration of, I wrote down some things about how to be a better hernia surgeon. There's no question from when I started to today, our considerations of anatomy have completely changed. You listen to Sean talking about the difference between the pre-peritoneal plane and the transversalis fascia plane. And I mean, no one would have ever discussed that 20, 25 years ago. It's beautiful to see those in lectures now, see them demonstrated robotically and beautifully and laparoscopically. The considerations of bipedical muscular advancement flaps. We never would have been talking about this even 15 years ago. And now it's commonplace. It is, we use common, the the consideration of even the way we speak, the architecture of our sentences has changed so much that it's almost like a different language in hernia repair. And our consideration of biomaterials, and then, there's perioperative management. I'll come back and I'm going to beat on this for a while, in our ability to take care of patients and facilitate better outcomes. And quite honestly, we have to be very serious here. We used to patch holes, and now what we are for most of these patients, we're patient quality of life doctors, and we have to accept that. And so, a hernia recurrence is one thing, but impacting negatively a patient's I'll take a hernia recurrence with a good quality of life versus a repaired hernia and a poor quality of life anytime. And I would do that certainly myself. And then some of these other things, like if you look at postoperative patient management, how many of you guys have raised your hand? How many of you guys have ever written a paper about a really good paper about drain management and what it means? And the answer would be zero. If you look at the last Cochrane study looking at drains versus no drains, even in ventral hernia repair, there's not one study that supports the use of drains. I mean, one of the things that all of us do with big abdominal reconstructions, and we have no data to support what we do. And then, of course, some of these general considerations at the bottom. This is just looking at ventral hernia. I know this is an inguinal hernia group discussion, but if you look at the number of peer-reviewed papers from the first paper that I found on ventral hernia repair in 1826 to more recently, almost 14,000 papers. And also, too, I'm certainly very pleased and proud of this. If you look at the growth in papers that are written about hernia repair, and this is just hernia, not ventral hernia, but you can see almost 100,000 papers. But I started writing about ventral hernia repair right here. My first paper was right here, but you can see this growth. And there were over 4,000 papers written about hernia, the most ever in the history of documented peer review about hernia repair. The interest in becoming a hernia surgeon is actually becoming pretty cool. And you can take all that information. This is a lady who's the largest peristomal hernia I've ever seen. This is actually her midline incision. You can see how her spleen is in this below her knee. And you can see this area where the bandage is. She's also got a mesh fistula over here after 7 failed ventral hernia repairs. And this is a peristomal hernia. She's been incapacitated for 15 years. And so this is in the operating room. And I love this girl's face in the background back here. And it kind of tells you as a hernia surgeon, it's actually pretty cool to be a hernia surgeon. But you can see your draining sinus. This is actually a midline incision. Use Steinman pins, and I'll go back. This is Ava Derenberg, who wrote the Small Bite, Small Walk paper. She was my fellow last year. And this is what she looked like in the OR. This is taking her abdomen apart, moving her stoma over to the other side. She had a chronic stoma, putting her back completely back together again. This was done with Botox. This was done with weight loss and no component separation whatsoever. And then, and this is what she looks like. And you can see her abdomen swollen a little bit because the Botox has allowed her obliques to continue to stretch a bit. And then after 3 months, they'll come back online. But she went from having to have someone, at the bedside to help her out of bed every day to 7 weeks after surgery to actually having her first job in 15 years. And as hernia surgeons, this is an amalgamation of all the data and all of the thought processes, over 20 years, 25 years of me doing this. And it's a beautiful thing. If you can't love this, you can't love surgery at all. I showed this when I was in India, and I'll just want to repeat this. This is one of my favorite analogies. This was a rocket that was actually fired from Europe. This was done about 11 years ago. And this is Rosetta. Rosetta was chasing the P-67 comet, and the Rosetta was the comet's only 2.5 miles wide, and the rocket traveled 4 billion miles slingshotted around Mars to catch this P-67 comet, traveling at 87,000 miles an hour. As it approached the sun, the Rosetta disassembled, and it sent a lander which actually landed on this comet. And this comet is not even a speck of dust in space. And they were able to, it sampled the atmosphere of this comet, checked the dust, took some high dust pictures, analyzed the dust, sent it all back to Earth. And this is just amazing. And if you look at what we know about hernia repair, we don't even know how strong to make mesh. If you look down here, the engineering that went into that and the engineering we have for the most common operation performed in the world, how strong does the mesh need to be? How much overlap do we need? How much fixation do we need? We're still talking about, Sean did a beautiful job going through inguinal hernia repair. And for God's sakes, we don't even, why are we still talking about that? Why don't we know? And I think that demonstrates, and for the young people who might be listening, all of these things and all the expansion of the research that can be done in this, and you're going to have a wide wake behind you. If you can answer these few questions, you're going to make everybody a better hernia surgeon, no question about it. And this famous quote by a physician at Stanford, I wouldn't be surprised if a large proportion of surgical practice is based on thin air and would evaporate if we studied them closely. I mean, what we need is close study. And the crazy thing is we've got all this population of hernia patients. We could easily do studies and, en masse and figure these things out, pretty darn quickly. What we always fall back to, and there are some technically gifted surgeons. When I was in India, some of these live cases, I was just amazed at how wonderfully these cases went. And the same thing when I was attended the last conference in Australia. And we tend to fall back and beat our chest and talk about what kind of surgeon we are. There's no question about it. And is that enough? And so this is a beautiful study that was done by John Berkmeyer's group. And John Berkmeyer works at the University of Michigan. He's done some amazing studies looking at surgical outcomes and quality improvement. And he worked with the Michigan Bariatric Surgical Collaborative here. There's also a general surgery collaborative, and I'm going to show a recent article from them in a few minutes. But what they did was the bariatric surgeons sent a video of themselves doing anonymously of them doing a gastric bypass. And these were hundreds of surgeons, and they rated them by quartiles. The lowest quartile, the middle two quartiles, and the highest quartile. And if you look at this, the yellow is the highest quartile, the best surgeons. And of course, they eliminated any complication, eliminated surgical complications, and eliminated reoperation. And so is surgical prowess important? Absolutely. But it's not everything. I showed this slide when I was in India 2 years ago, that was almost exactly 100 years when I showed this slide. And this is Sir Clifford Albert. He was a surgeon at that time who was the president of the British Medical Association. And what he said is there was an expansion of medicine from an art of observation and empiricism, which means I see my patients, I see what I have done, this is what I have been taught. And so with this empiricism, I learn from my experience. And he said, instead of that, we need to add science. And there's no question about it. And so I think that if you just rely on what you see in your own clinic, one of the problems is it takes a long time to figure out that you need to change, that there are complications or problems if you're just doing observation. And how do we become better surgeons? Again, we have to dedicate ourselves to at least these things. And if you look at where you can immediately impact better outcomes, it's in prehabilitation. I've talked about this many times, but it's so remarkable to me, even in our own institution, when we've actually demonstrated this. And as hernia surgeons, I think it's really quite remarkable that we believe that we are such good surgeons that we don't have to pay attention to prehabilitation. You want to be a better surgeon? Start in clinic. Especially with abdominal wall reconstruction patients, these patients are high risk. You can impact tobacco, obesity, and diabetes. And this was a study where 936 consecutive patients in our clinic, and 77% of them were these at-risk patients. This is a paper that we published on 775 consecutive component separations performed at our institution. And we learned an awful lot from this. But to highlight the consideration of the complexity of these patients, 775 component separations. And what I like to do because hernia patients are so hugely different in their size, in the size of the defect, how many failures they had, where they're located, I try to skim off of the ideal set of patients, and does this technique work in the standard set of patients? And what I did was we took out diabetes, tobacco, BMI of less than 35, and why not less than 30? Because we'd have no patients in this study. They got the fascia closed and non-contaminated. And if you look at it, 78% of these patients were very complex. And so again, we have to start in clinic and we can improve our outcomes. And this is the CEDAR app, and some of you guys will know about this. This is an app that we put out, which demonstrates how we can improve. This is 501 patients that we did abdominal wall reconstruction in. And in this app, it's available in the iTunes store and the Apple store for free. You can put these surgical considerations preoperatively and operatively and then figure out what the chance of wound complications are. But smoking, obesity, and diabetes, and a hemoglobin A1C of less than 7.2 or less is what I'm looking for. And people say, well, that's pretty tight control. My answer is, you're welcome. It's going to improve your outcomes. And so I've been questioned before, that just happens in Charlotte, North Carolina. So we did a study with Alfie Carbonell and Will Cobb at their institution, 915 of their patients, and we put them through our algorithm. And you can see the area under the curve at 0.75. We predicted their outcomes better than our own. And we've actually now, a group in the Netherlands has done exactly the same thing. So it is about tobacco, it is about diabetes, it is about smoking, and also some of the operative considerations, no question about it. And so if you would just draw your attention for us controlling preoperative factors down here for wound complications, we almost halved our wound complications by paying attention when we start. Instead of saying, I'm the best surgeon on the planet, I'm the smartest person in the room, taking care of your patients. And with that, our hospital estimated we had saved about $3.6 million in those 700 patients. And even when you break it down, you can see per point of BMI reduction and how much it saved. Now I'll say this is charge up here instead of cost, but in charges to the patient, stopping smoking is worth about $5,000. Every point of BMI down to a BMI of 26 saves money. Hemoglobin A1C reduction saves money. There is no question about it. How about in small defects? Well, I got an umbilical hernia, an epigastric hernia. I don't need to pay attention to that stuff. I just need to get the patient in the operating room and get them taken care of. If you look at beautiful work done from the Danish hernia database by Nadja Hendrickson and through Bisgaard and Helgestrand, if you look at smoking, and if you operate on smokers, the chance of wound-related complications or readmission is significantly higher. And if you look at a BMI of greater than 40, it's a 6-fold increased chance of complications in admission to the hospital. I mean, does it matter in small hernias? Even in small hernias. And so this just came out this past week, and JAMA opened from I mentioned the group from Michigan. And so why aren't we doing this? And you'll see that, I'd love to say that we're sticklers about optimization, but we're not, in this day and era, in this day and age, it's about patient satisfaction. And these patients will go see somebody else. They'll write a bad review about me. I mean, you can put it on, you can make it the patient's fault. Of course, at big universities, you can draw the line, but in communities, I think we're stuck with that. I mean, now you're blaming your community. The consideration of like, well, I love this quote. It's always for me about the patient. But as far as outside factors, the administration would just love for us to operate and use the robot, because now you're blaming the administration. There's lots of excuses versus just saying, this is it's my responsibility. The American College of Surgeons have said, the statement of the principles of underlying preoperative responsibility, the surgeon is responsible for the proper preoperative preparation of the patient, minimizing the risk of the operation while providing maximal opportunity for satisfactory outcome. It belongs to us. And so you can take even a step further, even starting a walking program. How do you be a better surgeon? Just have your patients walk prior to surgery. And there are beautiful studies just showing short walks prior to surgery improves outcomes, improves functional capacity, and an improvement in rehabilitation, decreases complications significantly. We actually won a grant from the American Hernia Society. And so we've started both a prehab program and a rehab program. And so for the prehab program, we do a baseline 6-minute walk when patients are in clinic, and then we give them a walking protocol, and then we repeat the walk on the day of the surgery. They show up for in the preoperative holding area. We take them on exactly the same walk and see how far they can walk. And our preliminary data, and this is how we fashioned this. We're working with 2 PhD physical therapists. I mean, finally, I'm getting smarter, maybe, and working with some smart people to tell me how to really do prehabilitation versus me just saying I need to do it. I can do it all myself. And so what we ended up finding is we had 100% patient compliance. If you actually talk to the patient and stress the emphasis versus saying, oh, they won't do it, don't be lazy. And so they increased the distance they could walk in 6 minutes by 900 feet and had an average of 15 pounds of weight loss prior to their surgery. And all we did was have them stress walking and demonstrated this and talked to them and took them on a 6-minute walk ourselves. And so people in our office, actually a research fellow, Celia Yuzo, a fantastic young surgeon he's going to be one of the best we've ever trained. This is one of his projects. And he just takes them for a walk and talks to them about how important it is for 6 minutes while he walks them. How about rehabilitation? If you get a new shoulder, you get rehabilitated. You get a new knee, you get rehabilitated. You get it, you have a heart surgery, you get rehabilitated. We are crazy as hernia surgeons. We reconstruct someone's abdomen, and we tell them not to lift for 6 weeks, and then, well, you can go start doing what you want and be careful, and we'll see you around. And that is our postoperative orders as far as rehabilitation. How can we be better surgeons is actually It's all about encompassing, accepting that we're true abdominal wall rehabilitation surgeons, right? And we need to then do the follow-up in the patient. So while the patient's in the hospital now, we've started a true rehabilitation program, and I'm hoping in about 4 months, we'll have the first 35 patients completely through this with follow-up, and I'll be able to tell you some really interesting stuff about rehab. The 4-step rehab program begins the day the patient, the post-op day 1, and then we have physical therapists meet them in the hospital. They go through every day, so they're fully educated, the 4 steps of rehabilitation of their abdominal wall. And I'm excited about this, and I think this is going to be something that's really going to change what we do as surgeons. And so I used to say it's just a hernia. My preoperative time was very short. Of course, my operative time was very reasonable, and then my postoperative time, because of complications, because I didn't spend time pre-op, my postoperative time was much longer. And then of course I thought it was very cool. And then I would say, well, look, my preoperative time is longer. I do all these things to get the patient ready. My operative time, of course, is about the same as it was, and my postoperative time is really short because of I didn't have complications. But now what I'm doing is my postoperative time, because of rehabilitation, is actually longer. And so I think that's, it is for this, I'll just tell you, without spending time here, you don't spend time here, you don't spend time here. And I told my fellow the other day, it's like a lazy hernia sandwich. It's all about what's in the middle. And what we can't do, if we're going to be real surgeons here and real caregivers, we got to do all of this. And so if you look at the consideration of stockfish, this is something, an analogy I really like. How do we really become better surgeons? I think this is super important. And to think about how do I progress as a surgeon? I'll use this analogy. Stockfish is an open access artificial intelligence chess game. And so essentially what they did with Stockfish is they taught it the rules of chess, and then they allowed Stockfish they fed it all of the masters games for over 100 years. So it learned from the masters, it learned from the best players. And then just a few years ago, for the first time ever, Stockfish beat the first time ever beat the international human champion. So can you, as a professional, learn from the literature, learn from experts, and therefore yourself become an expert? And I think that is a really good way to learn how to become a surgeon. And how did I become the surgeon that I am, still seeking expertise? And I mean, truly, it's about the people. A lot of people who are actually in this group have actually taught me an awful lot about surgery. All of these people have made me the surgeon that I am. And I'll just show this picture of Tom Hugh. And Tom, you might want to take a screenshot of this, put this on your desk, give it to your wife, because you're looking as nice as perhaps I've ever seen you. You're welcome. And so, but yes, everyone has affected me and made me certainly a better surgeon. Love this thing. This is AlphaZero. This is Google's computer chess AI. And so what Google actually did, instead of feeding it the rules and then feeding it all the literature, it fed it the rules and then let AlphaZero play itself over and over and over again. And so what AlphaZero did was it discovered its own weaknesses. And as it played itself over and over and over again, and learned from its own mistakes, it became a better chess player. Really quite remarkable that allowed it to play itself. And that's the big difference with Google. And so then they faced off AlphaZero versus Stockfish, and AlphaZero destroyed Stockfish. No losses, 27 wins. And so, yeah, you can become a really good surgeon by learning the literature. You can become an excellent surgeon by finding out from your own mistakes and improving. And I think this is, I mean, the best way the way I've become a better surgeon indeed is by learning from my own mistakes. And this is just a sample of improvement that we've made. And every single point in this line, I'll just tell you that is quality improvement. And that's going back and our fellows writing up papers saying that where we've made mistakes and how we can improve. Absolutely. And this is continuing. I look forward every day coming in. I tell Celia Yuzo and my fellows all the time, if you can't make me a better surgeon while you're here, then you fail. This is this statement by Norman McLean, and so I'll just tell you too. People think that, well, I'm a good surgeon. Patients will come back and see me. They like me, and I'll find out if there's a difference, and whether I should change. There was Amos Tversky is a very famous mathematician and social scientist who ended up winning the Nobel Prize after he had died at a young age, actually. And one of his famous experiments, he had just two lights on in a room, and the lights would come on and one of them would come on 60% of the time, one would come on 40% of the time. And he asked the participants, tell me which one is coming on more than the other when you're sure about it. Something super simple, right? Well, you ought to be able to tell by 38 times the lights come on, 38 times, and you should know mathematically. But on average, it took 505 times the lights came on before someone would say, well, I think there's a difference in this one's different, this one's more. And that doesn't include all the considerations of surgery. So, scientifically following your outcomes, and so like changing how I would take care of patients, and this is an algorithm in taking care of complex patients. All of this has changed because of following our patients and figuring out. I mean, this would have been super simple 15 years ago, 20 years ago, but now the complexity and figuring out how we've made mistakes makes it better. You can't be like a surgeon like this guy in this outpatient surgery journal, where he said in his interview, he's seen 2 hernia mesh infections in 14 years he's been in practice, and neither was his fault. I mean, we can't really live like this. And maybe it's just me. I mean, perhaps I just have too much fault in taking care of patients. It's interesting, there's comments about from surgeons. I would know if there's a problem and my patients really like me and they think I'm a really good surgeon, they come back to me. So we did a survey of 150 patients, and 72, and these all patients had all recurrences or hernia-related complications, and 72% of them said their surgeon had no idea they're in our office. And 67% said they liked their surgeon as a surgeon, thought they had good skill, and rated their bedside manner very high. So they liked them. They thought they were good people, but they still didn't go back to them. I mean, indeed, it is about follow-up. And one of my favorite slides of all time about things that tell the truth, and you can read that for yourself, but certainly very true. I've stolen this slide and used it a few times. This blue line is, how much I think I know. This yellow line is how much I realize there is to know. And this green line is, how much I actually know. And this is that consideration of observation and empiricism. We tend to have short-term memory and bad long-term memory as surgeons. And really the way to improve is to actually realize how much that we know so little, especially in hernia repair, and learn from your own mistakes and learn from others, versus just accepting how great we are. Adductive versus deductive reasoning. This comes from Sherlock Holmes. Deductive reasoning, whatever in deductive reasoning, it's always true. Like in Sherlock Holmes, here's the blood, here are the fingerprints, here's the weapon, and here is like the movement of people. It doesn't change. And so it's always true. And what we have to expect in medicine is adductive reasoning. And I'm hoping that the things that you guys are going to talk about today, it's not that they're not going to be true, but they're going to be surpassed. We have to say that this is what we're talking about today is the best available things in medicine and best available things in surgery. If we don't accept that there will be change, there'll be no growth in medical care. We have to assume what we're saying today is going to be wrong. And it's a wonderful thing to think about. Absolutely. If you look at the progression of surgeons, people live in arrested development. There's no question about it. And so the consideration of living in arrested development, and where people tend to live here, and then and don't seek expert performance, they don't change. What we have to do is benchmark ourselves against our past, of course, but I would think about it in another way. You benchmark yourself against the past to show improvement, but also you want to benchmark against your future, especially the young surgeons today. If you don't seek improvement, you'll slowly decrease in your true knowledge and ability simply by erosion. As John Wooden said, it's what you know it after you know it all that really counts. But one thing I also will, I think we need to be very careful about is the consideration of the prospect theory. Again, this comes from Amos Tversky, again, super smart guy. And we as aggressive, competitive human beings, or you wouldn't be a surgeon if you were not, is we tend to want to maximize good outcomes, and we tend to sometimes to overexplore. We have these anticipated perceived gains versus perceived losses, and this unknown possibility despite diminishing outcomes. We have to be very careful about, we don't want to be left behind, but as Peter Drucker said, if you're going to do something new, you have to stop doing something old, and you have to be able to to consider the science of something new. This is a slide I made a couple of years ago demonstrating fallacy of surgeons. And I'm talking about phasic sales, and I'm not going to blame Bard. Bard is doing what Bard does. Bard's supposed to sell you mesh. And for us as Americans, this comes from the American surgeons. And the phasics was first introduced in 2013. You can see the sales in dollars. And by August of 2017, $166 million in sales, greater than 36,000 patients were treated. And this was the first clinical article, the first data, the first scintilla of human data came out in August of 2017 when greater than 36,000 patients have been treated for their hernia with phasics. Not Bard's fault. There was not a single human case report during those 5 years. And 36,000 patients received this mesh. And if this mesh fails, that's on us. No data. We want to, by marketing and by contracting, we put all this mesh in. We have to be better. There's no question about it. And about like robotics, again, it is really cool. Every one of our fellows has to learn how to do the robot. And what we don't want to be is like Napoleon when he talked about the steamship. You would make a ship sail against the winds in currents by lighting a bonfire under its deck. I have no time for this nonsense. We don't want to be like that as surgeons, but we have to assess the technology. And robotics is very cool. Every one of our fellows has to get robot trained. And yes, I started doing robotics. The sweet spot for me in doing robotics is what I would do open, and it's about length of stay. The most impressive thing about robotics is not like the cool videos, but where's the sweet spot? Where do you really make a difference? For me, the average size defect I've done, they're all ventrals, no inguinals. If you're going to operate me in the groin, laparoscopic versus robotic, you got to get on your horse. And so, but the most impressive thing is everyone met qualifications to be discharged on post-op day 1. Really impressive. And so I'll say that, but then, I will tell you that, the consideration of hernia outcomes and inguinal hernia with robotics. And again, I'm not here to beat on it, but when I hear people, and even in our own institution say, robotics is faster, it's better, it's even cost effective, and the outcomes are better. And if you're going to say that to me, then I'm going to test it. And so opening or hernia, laparoscopic and robotic, you can see that opens were more complicated, 31% recurrent, more comorbid. And we do these under local anesthesia frequently in our cardiac patients. So, and you can say 30%, 20%, 10% essentially for the recurrent hernias. But if you look at the hernia recurrence rates down here, they're exactly the same. And if you want to look at the time for surgery, significantly greater time, even though people are saying, I do them faster. The people who do the robotic inguinal hernia repairs, we actually looked at them compared to their own laparoscopy, significantly longer time robotically than laparoscopy. And I just think that people didn't know what their outcomes were. And so without knowing what your own outcomes are, it's hard to speak truly authoritatively. And so I think there's a difference between truth and knowledge. And I'll point to the bottom down here. Technology is not truly important or useful until it's boring. And what is meant by that is the consideration of you let the technology get out in front of you. You have some really smart people test it, drive it, see what the outcomes are, teach us how to do it. And then it actually becomes boring. And then the rest of us can do it versus 36,000 patients being treated with a mesh, we have no outcomes, or everybody running to the robot and trying, because it's so cool and you can't be left behind and it's a marketing tool. I think we have to be very careful. And like Einstein said, the perfection of tools and the confusion of goals is a product of our time. As a community of hernia surgeons, how do we make ourselves better is reliance on each other versus running to the next great thing, because we can't be left behind. Some really, really talented surgeons. And I think we need to be organized better. No question. Like the McNamara fallacy, McNamara only measured the number of deaths in the Vietnam War. He was our Secretary of Defense and measured nothing else. We can't just do that. We have to measure the full spectrum for our patients. Lastly, and I'll shut down after this, how do we do better? It's perhaps now is personal, professional, but also there's societal betterment. I'll even talk about research and teaching, the standardization of best practices, programmatic development, and then like once you get smart about what you're doing and you can present to your peers, I think presenting the complications and your problems is as important as your victories. Absolutely. And I'll even show the slide. That was the introduction to this lecture. And Sonia Yuzo is one of our research fellows. and Sully, I'm sorry, Yuzo. And so Sully actually helped me put this lecture together. And part of my teaching, part of my doing this lecture was to teach him. And somebody mentioned, Sue nicely mentioned some of the people that I've had to train. If there's one thing I've done well in my life, is teaching, and teaching people to also be passionate about this specialty. Most of the people on this slide, and I call these guys the pronouns of hernia repair, the kind of the who, where, what, and how of abdominal wall reconstruction. Of some of the young kids that I've trained, and now people who are my peers. Absolutely, this has been the best part of my life, and then becoming socially part of their life. And I'll just tell you, and I'll close with this, how do we be better surgeons and better hernia surgeons? I think societally, for young surgeons, we frequently will say, and I can put myself in this, we worry about young surgeons these days and their training. And I think that doing better, we need to let them decide what's doing better as a hernia surgeon for them. Indeed, it may not be having a corner office or driving a big car or making a big income. And I'll just tell you, if they, as surgeons, if they can simply treat women and people of color as strong and capable and equal, they will have done better than many of us. And if they see race and ethnicity and gender identity as attributes and not stereotypes, they will have done better than us. I think doing better is often not, or should not be found in a paycheck or be mathematical, but should be emotional or intellectual and or even spiritual. And I think many of my young surgeons have really taught me that over my life. And I think that what makes us better is often punitive. We need to be faster, thinner, more fit, and I think it's all ridiculousness. And as Nigel Marsh, a famous Australian expert in time management, said, famously, too many people in this world work too hard to make more money than they need, to buy things they don't want, to impress people they don't like. And I think that young people, some of these young people actually maybe will do better than some of us who've driven really, really hard in our lives. Jenny Shaw's the young woman on the right-hand side, and when she was interviewing with me, she gave an answer to my interview questions, which really kind of changed my life. She was my 5th interview of the day, and I asked her the stupidest question ever. And I said, so Jenny Shaw, so why would you be a surgeon? And she actually laughed at me, which really caught me off guard. And she said, why surgery? It's the most optimistic field of medicine. She said, in 3 hours, I can cure you of cancer. In 2 hours, I can take a sick child and hand them back healthy to their parents for decades of life. I can take a trauma victim, and in 3 hours, I can put them back together again. Why surgery? Beautiful answer. I just want to thank you guys all very much for allowing me to participate in this and in the honor of the Zoom instead of the podium. Thank you.
That was an excellent talk. As a younger fellow myself, that's certainly very inspiring and lots to reflect on. And I think I had Vivek there having a few things he wanted to say.
Well, I think I absolutely agree with the sentiment and the messages which have been coming in the chat box. It was a wonderful and amazing talk, a lot to learn. And in fact, every slide in itself was a starting point from where we can have another lecture by Dr. Heniford sometime. So it was an amazing talk. Thank you, Professor.
Thank you.